Manila Doctors Hospital section of Gastroenterology and Digestive Endoscopy. He also
Congratulations to the section of gastroenterology, and especially to the organizing committee, and thank you for inviting me to be part of this event. I was tasked to discuss about approach to upper abdominal pain, or I would say basic diagnostic approaches to abdomen. Abdominal pain can be a challenging complaint for both primary care and specialist clinicians because it is frequently a benign complaint. However, it can also herald serious acute pathology. It is important to determine which patients can be safely observed or treated symptomatically at home and which patients would require further investigation or specialist referral or even admission. The evaluation of abdominal pain requires an understanding of the possible mechanisms that is responsible for the pain. Pain receptors respond to both mechanical and chemical stimuli, and stretch is a principal mechanical stimulus, although distension, contraction can also be perceived. Basically, there are two types of pain. One is visceral and the other is somatic pain. Visceral pain in general results from stretch of the smooth muscle and is localized in one of the David-like zones, namely the epigastrium, mid-abdomen, and the lower abdomen. The innervation of this visceral area is through the right and left splanchnic pathways. That's why it is poorly localized. It is usually described as dull, aching, constant pain to cramping abdominal pain. Nausea, vomiting, pallor, and sweating are usually associated with visceral pain. Somatic pain is located asymmetrically and it is well localized. The innervation, which is unilateral, hence any stimulation of the parietal abdominal surfaces are lateralized quite well. It is intensified by jarring, deep inspiration, or pressure on the abdominal wall. Unlike visceral pain, nausea, vomiting, pallor, and sweating are rarely accompanied with somatic pain. It is important to note that the threshold for perceiving pain may vary among individuals and in certain diseases. Most patients with abdominal pain have a benign and/or self-limited etiology, and the initial goal of the evaluation is to identify patients that may require urgent intervention. A thorough history and focused physical examination will lead to differential diagnosis and further evaluation with laboratory tests or imaging studies. During evaluation, it is important to focus on six important features. One is onset, and then progression, migration, character, intensity, and localization of pain. Abdominal pain may be sudden, rapid, or gradual in onset. Pain of sudden onset occurs within a second. Patient can relate the time of onset at a precise moment. It is usually associated with perforation such as septic ulcer disease and ruptured aortic aneurysm. Pain of rapid onset begins with a few seconds and steadily increases in severity over the next several minutes. Patient can record the time of onset in general, but without the physician noted pain of sudden onset. It is commonly associated with cholecystitis and pancreatitis, while pain of gradual onset is pain that slowly becomes more severe only after a number of hours, even days have elapsed. Here, the patient's memory as to the time of onset of the pain is vague. Patient cannot recall or remember the time of onset, and this one is usually associated with neoplasms of chronic inflammatory process. The history of a patient with abdominal pain also includes determining whether the pain is acute or chronic. However, there is no strict time period that will classify whether it's an acute or chronic type of pain. But in general, pain of less than a few days duration that has worsened progressively until the time of presentation is considered acute. So usually it is less than 1 week duration. While pain that has remained unchanged for months or years can be safely classified as chronic. So there's a constant or intermittent pain for at least 6 months. Pain that has remained unchanged could be classified as chronic, but in between acute and chronic, you may call it subacute in onset. It is important to determine the progression of pain over the interval from the time of onset until the patient seeks medical attention. So important questions to ask are, has the pain abated or increased? Have there been intervals of total absence of pain, or has the pain always been present, changing only in character? With these information, The clinician will be able to narrow down its differential diagnosis. Pain originating in the viscera is sometimes perceived as originating from a site distant from the affected organ. Referred pain is usually located in the cutaneous dermatomes, sharing the same spinal cord level as the visceral inputs. One classic example is acute appendicitis. Usually it starts with the epigastric pain early in the course of the disease. Then it is produced with the right lower quadrant pain later in the illness when the parietal peritoneum becomes involved with the inflammatory process. Another example is acute cholecystitis. Inputs from the gallbladder enter the spinal cord at T5 to T10 level. Hence, pain from an inflamed gallbladder may be perceived in the scapula or the right shoulder. Determining the character of the pain or what kind of pain the patient is experiencing is also important, discovering the pathologic process responsible for it.
Recording in progress.
Pain such as brushing occur, wherein you see this in most of the time in esophageal disorders, burning, infected tissue disease, breathing, as seen in the small fracture. However, the two common types of pains are one is cramping and another is dull or aching pain. Cramping abdominal pain is characterized by pain that increases in intensity in short waves to a maximum and then abruptly stops for a period of complete absence of pain. This is usually associated with mechanical small bowel obstruction, while constant dull or aching abdominal pain is usually caused by distension or edema of the wall of the hollow viscus, such as seen in pain secondary to liver and spleen disorders, wherein there will be stretching of the capsule. It is also associated with pain coming from gallbladder secondary to obstruction of the cystic duct. Each patient perceives pain intensity differently. Intensity of pain can be assessed by the way in which the patient physically responds to it. For example, patients with peritonitis, they tend to lie still with the knees and hips flexed. However, patients with pain arising from the hollow or viscera, patient cannot lie still but constantly change position or move about. The best way to check for the presence of somatic abdominal pain is to ask the patient to distend his abdomen alternately by pushing out his umbilicus to touch the examiner's hand, which is held a few inches above the abdomen, and then to suck in his umbilicus to touch his spine. This stretching procedure often identifies the site of somatic pain. It is well to have the patient indicate also the site of the pain while standing and in the prone position to be certain of the true location. Included in the history taking is determining what precipitates a patient's pain. For example, pain of duodenal ulcer may be relieved by eating and recurs several hours after a meal, while pain of pancreatitis is classically relieved by sitting up and leaning forward. Peritonitis often causes patients to lie motionless on their backs because any motion causes pain. Symptoms such as fever, chills, fatigue, weight loss, anorexia would be concerning for infection, malignancy, or even systemic illnesses. While symptoms such as cough, shortness of breath, orthopnea, extensional dyspnea may suggest a pulmonary or cardiac etiology. We also have to ask for other GI symptoms such as nausea, vomiting, the presence of hematemesis, hematopesia, or melanoma. While patients with right upper quadrant pain or liver disease, we have to ask for the history of jaundice and the changes in the color of urine and stool. Females should be screened for risk of pelvic inflammatory disease and should be asked about their menstrual history. For the past medical history, one important thing is to ask for the history of surgery and procedure because this can assess the risk for differing etiologies. For example, a history of abdominal surgery could be a risk factor to develop post-operative adhesion, which can then lead to gut obstruction. Same is true with history of cardiovascular disease in patients with epigastric pain may raise concern for a myocardial ischemia. A comprehensive medication list should also be elicited as this can inform the other differentials such as the use of antiplatelets, NSAIDs, steroids in patients with peptic ulcer disease or in patients with GI bleeding. It is important to ask about alcohol intake to assess for the possibility of liver disease or pancreatic disease. This is also true for family history, especially those with history of malignancy. All patients should have abdominal examination, and the first one should be always be inspection. So during inspection, general appearance, the level of comfort or discomfort of patient should be noted, and you should also check for the presence of scars, distension, or pulsations. You should also include attention to the position assumed by the patient when in pain. Remember that patients with peritonitis, most of them tends to be immobile with worsening of pain when the examiner even lightly bumps the stretcher. The abdomen should be auscultated for vowel sounds. Abdominal fluid can be heard in patients with aortic aneurysm, while abnormally active high-pitched vowel sound, or we call that metallic sound, can be appreciated in early bowel obstruction. Friction rod in the appropriate area might be heard in a patient with splenic infarct. Supposition splash is also known as gastric splash, which is a sloshing sound heard through a stethoscope during sudden movement of the patient on abdominal auscultation. It usually signifies the presence of gas or air in an obstructed organ, such as seen in gastric outlet obstruction. It is elicited by placing the stethoscope over the upper abdomen and rocking the patient back and forth at the hips. So next one is percussion. Ideally, we have to start with gentle percussion even before palpation. So it can help identify patients with peritonitis or organomegaly such as hepatomegaly. A tympanic sound signifies a distended bowel, such as seen in patients with ileus, and dullness may signify a presence of mass of fluid. Shifting dullness is a reliable and fairly accurate sign for the detection of ascites and is usually present if the volume of fluid is greater than 1,500 ml. It is usually performed by first percussing the midline, so eliciting tympanic sound, then it is moved progressively more laterally or away from the examiner. So we then ask the patient to change from supine to lateral declivity position, wait for about 30 seconds. Shifting dullness is present if percussion of the dependent portion shifts from a dull sound to a tympanic sound. So remember that this is a tympanic sound and this is the fluid at the dependent area during supine position. So if you ask a patient to shift to a lateral position, fluid will then go to the dependent area. So this previously dull sound will be shifted to tympanic sound on percussion. So lastly, palpation. It is used to evaluate tenderness of the abdomen and for enlarged organs or masses. So always start examining the quadrant of the abdomen when the patient is experiencing the least pain. Do not start with the one that the patient is pointing. So with bone tenderness, we reflect peritonitis. So patients with localized upper abdominal pain, such as those with right upper quadrant pain, may not require a rectal examination except in cases of GI bleeding. Upper abdominal pain syndromes typically have characteristic locations, such as in right upper quadrant. Most of the time, it pertains to a biliary or hepatic etiologies. So these are the different causes of epigastric abdominal pain. Myocardial infarction, acute or chronic pancreatitis, peptic ulcer disease, reflux diseases, gastritis, gastropathy, functional dyspepsia, or gastroparesis. So of important note is the abdominal aortic aneurysm, which has a classic triad of hypotension, pulsatile mass, or abdominal pain. Pain involving the liver or biliary tree is generally located in the right upper quadrant, but it may also rotate to the back or epigastric. Because hepatic pain only results when the capsule of the liver is stretched, most pain in the right upper quadrant is related to the gallbladder or biliary tree. Symptoms of biliary colic includes intense, dull discomfort located in the right upper quadrant. It is usually associated with nausea, vomiting, and diaphoresis. It can last for about 30 minutes, plateauing within 1 hour. Most patients will have a benign abdominal examination. One classical example is gallbladder stone. So other causes could include acute cholecystitis, acute bronchitis, and sphincter of OD dysfunction. So for hepatic etiologies, it includes acute hepatitis, perihepatitis, or Fitzhugh-Curtis syndrome, which is usually seen in young female with pelvic inflammatory disease and is described as right upper quadrant pain with a pleuritic component. Liver abscess can also cause right upper quadrant pain, same is true with Biliary syndrome and portal vein thrombosis. Left upper quadrant pain can be caused by splenic etiologies. Remember that the usual causes of epigastric pain are more common than splenic etiologies. Hence, the pain from these disorders may atypically present also as left upper quadrant pain. So, splenomegaly, splenic infarct, splenic abscess, splenic rupture secondary to abdominal trauma, all of them can cause left upper quadrant pain. So, what do we learn from the previous slides? Most diagnosis of upper abdominal pain still it relies heavily on thorough history and physical examination. It has been said that the skilled clinician can identify the source of abdominal pain from the history and PE alone 80 to 90% of the time. So diagnostic tests such as laboratory imaging tests will just usually confirm our initial impressions. So usual tests that we request are CBC with differentials, electrolytes, blood glucose, especially for those with pancreatic problem, liver enzymes, amylase or lipase, and abdominal ultrasound as the initial imaging test. Patients with epigastric pain and cardiac risk factors should also have ECG or chest X-ray, and endoscopy may be indicated if there's concern for GI bleeding or severe petrification disease. So at the conclusion of the initial workup, young patients with no evidence of organic disease can be treated symptomatically. So pregnancy should be excluded in all females of childbearing age with abdominal pain. A diagnosis of new onset functional illness should be made only with great caution in patients over 50 years of age. These patients, by virtue of their increased risk of malignancy, will likely require abdominal imaging as their signs and symptoms dictate. So, based on the recommendation of case published in the American College of Radiology, if you are highly thinking of acute abdominal pain associated with abscess, so the first imaging test to request would be a CT scan. While in acute pancreatitis, ultrasound is usually the initial test, but you have to consider CT scan if ultrasound is non-diagnostic, presentation is atypical, or the patient is critically ill. While for patients with or in cases of polycystitis or those patients with right upper quadrant pain, ultrasound is still the initial imaging of choice and not CT scan. So, in summary, abdominal pain is a common problem. Most patients have a benign or self-limited etiology. There is no substitute for a careful, proper history and physical examination. Remember to always ask for the onset of pain, progression, migration, character, intensity, and localization of pain. As much as possible to narrow the control different diagnosis, try to cluster all the symptoms that can come up with one diagnosis in order to guide further management and investigation. Thank you for your time and thank you for listening.
Good afternoon. Today we will study the very first step in the treatment of acute pancreatitis, fluid therapy. To do so, we will review acute pancreatitis, diagnosis and severity grading. Then we will look at the specifics of fluid therapy. Acute pancreatitis is diagnosed as the presence of any two out of three features: acute persistent, severe epigastric pain, serum pancreatic enzyme at least 3 times the upper limit, and characteristic findings of imaging. It is classified into 3 severity grades: mild with no organ failure nor complications, moderately severe with complications or organ failure lasting less than 48 hours, and severe with organ failure lasting greater than 48 hours. There are 2 thresholds in the development of acute pancreatitis. Threshold 1 is exceeded at the onset of disease, and threshold 2 is exceeded at the progression to severe disease, increasing the risk of death. These thresholds are the balance between stressors and protectors. Stressors like amplification loops will diminish ATP supply, causing necrosis and inflammation and increase the likelihood of exceeding either pressure. Protectors like effective treatment will reduce the impact of stressors. Effective treatment involves treatment not only of acute pancreatitis but also of its etiology. To treat acute pancreatitis, fluid status, analgesia, nutrition, and complications have to be addressed. The rationale for hydration in acute pancreatitis arises from the frequent hypovolemia that occurs from vomiting, anorexia, fluid third spacing, respiratory losses, and diaphoresis. In pancreatitis, pro-inflammatory cytokine and vasoactive mediators rise during the first few oscillating concentration of these mediators and therefore complications. Aggressive hydration may have little benefit beyond 24 hours. Delayed fluids may even worsen mortality risk. In 2020, Biliary Monterrubio compared aggressive versus non-aggressive hydration in mostly mild acute pancreatitis presented more than 24 hours from disease onset. They did not find significant differences in SEERS, pancreatitis severity, complications, or clinical improvement. These are the guidelines for the management of acute pancreatitis. The ones in red are specific for severe pancreatitis. They recommend hydration within 4 hours of diagnosis, 12 to 24 hours of admission, or 48 hours of disease onset. Essentially, hydration should start as soon as diagnosis is established. Fluid status may vary widely due to several factors. We will discuss severity later. Patients who present earlier may have smaller deficit than those who present later. Heart failure, renal failure, pulmonary and liver diseases may affect tolerated volume. The elderly may require caution to avoid volume overload. Fluid status includes intravascular volume, fluid sequestration, and fluid responsiveness. These will help determine the volume needed based on the principle of balancing inputs and outputs. Intravascular volume can be reflected in clinical and laboratory parameters. Clinical parameters include heart rate, RR, UT, MAP, and urine output. Lab parameters include hematocrit, BUN, creatinine, plasma proteins, and lactate. For lab parameters, not only the absolute level but also the trend should be noted. Hemoconcentration by itself may suggest either vascular leakage or simply fluid deprivation. Fluid balance in the prior 24 to 48 hours will help differentiate between the two. Estimated median fluid sequestration is approximately 4 liters per 48 hours in acute pancreatitis. A hematocrit of greater than 44% predicts pancreatic necrosis and persistent organ failure. High BUN also predicts pancreatic necrosis. If BUN is greater than 20 mg per deciliter, the target is a reduction of at least 5 in the first 24 hours. Lactate may be a marker of adequate tissue distribution. Fluid sequestration can be reflected indirectly by hemoconcentration and low plasma proteins. It can also be assessed clinically by edema, pleural effusion, and ascites. Sequential management of intra-abdominal pressure is recommended for cases with excessive fluid infusion, severe pancreatitis, renal and respiratory complications, and multiple fluid collections. When there is persistent or recurrent IAP greater than 12, there is intra-abdominal hypertension. Conservative management includes GI and intra-abdominal compression, improvement of abdominal wall compliance, appropriate fluid infusion, and circulation management. When IAP is greater than 20, there is abdominal compartment syndrome. Surgical decompression should be considered when conservative treatment is not effective and when there is concern for organ failure. The onset of ACS increases mortality. Fluid responsiveness can be assessed by non-invasive and invasive parameters. Non-invasive parameters include MAP and passive leg raising. In spontaneously breathing patients in critical condition, cardiac output increase greater than 10% within 60 to 90 seconds of passive leg raising, IVC collapse index less than 48% predict fluid response. However, in mechanical ventilated patients with IAP greater than 16, these are difficult to interpret. Invasive monitoring is indicated in cases of pancreatitis-associated shock. As these indicators have limited accuracy, they need to be used together to avoid misjudgment, which can lead to serious adverse consequences. For clinical parameters, continuous monitoring of MAP, heart rate, and urine output is suggested, especially for severe pancreatitis. For lab parameters, they recommend frequent hematocrit and BUN every 6 to 12 hours for the first 24 to 72 hours. Some experts even suggest every 4 to 6 hours testing, especially with severe pancreatitis, oliguria, comorbidities, and older age. For invasive parameters, CBP is most commonly recommended. If these targets have been secured, a reduced fluid infusion rate guided by frequent reassessment is suggested. If these targets are not attained, the patients may not benefit from continued aggressive hydration. This is especially true. These endpoints suggest impending volume overload with improvement in end organ perfusion and with unstable circulation dynamics. For example, decreasing saturation with tachypnea and increasing IAP, but persistently low urine output and or hypotension. In this case, persistent aggressive hydration should be stopped and continuous hemofiltration or hemodiafiltration may be considered. In some cases, small doses of diuretics may be used to prevent tissue edema. Insufficient or slow hydration will adversely affect inflammation control and organ function. Fluid dynamics are fundamentally different in mild and severe pancreatitis. In mild pancreatitis, there is only local inflammation. As such, the neurohumeral fluid regulatory mechanisms and capillary circulatory functions are preserved. However, there may be a fluid deficit due to low intake and vomiting. Aggressive fluids could lead to better pancreas perfusion and hence excretion of cytokines via diuresis. There are two RCTs on fluid rate in mild pancreatitis. Both excluded severe pancreatitis, but ang subacorn in 2021 included some with sears. Both use the same method of lactated weaners, 20 ml per kilo dose plus 3 ml per kilo per hour versus half the dose. Meta-analysis showed no significant difference in persistent sears and clinical improvement. No patient developed volume overload in both RCTs. However, books bound each show significantly more clinical improvement with aggressive hydration. Could this be because ang subacorn included patients with sears at baseline? The presence of sears had been reported to predict mortality in acute pancreatitis. Books bound also showed that this aggressive hydration. In this study, only one patient developed severe pancreatitis, multi-organ failure, and death. This patient had not progressed hydration. Subacorn, on the other hand, also showed that among the obese, there is significantly more clinical improvement at 24 hours with aggressive hydration. Obesity has the potential to worsen the severity of pancreatitis. Lipolysis of visceral fat releases unsaturated fatty acid that inhibit mitochondrial complexes, synthetic necrosis, and inflammation. There are no specific recommendations for mild pancreatitis, but the 2019 Taiwan Pancreas Society suggested aggressive hydration. Considering there were no volume overload and there were some positive results in RCTs, it's safe to follow their regimen. However, if there is contraindication to bolus, the 2015 Japanese 2013 international guidelines may be followed. In severe pancreatitis, necrosis leads to systemic release of damage-associated molecular patterns and free fatty acids. These activate immune cells to release various cytokines that may disrupt the functions between vascular and endothelial cells. Endothelial injury will increase capillary permeability, causing plasma leakage into the interstitium, intravascular volume contraction, and tissue hyperperfusion. Plasma proteins in the interstitium will in turn increase interstitial osmotic pressure, causing impaired fluid resorption, fluid sequestration, and tissue edema. The pancreas, tissue hypoperfusion, and edema will lead to ischemic injury to acinar cells and more pancreatic necrosis. Elsewhere, these combine with a cytokine-derived inflammation to cause organ failures. For example, in the lungs, this may cause pleural effusion, non-cardiogenic pulmonary edema, and ARDS. In the heart, this may cause cardiogenic shock. In the kidneys, this may cause interstitial edema and acute tubular injury. Other complications are abdominal compartment syndrome, venous thromboembolism, and death. The amount of volume depletion due to extravascular leakage may vary due to different propensity for fluid sequestration. The independent predictors of fluid sequestration in the first 48 hours are younger age, alcoholic etiology, higher hematocrit, hyperglycemia, and higher creatinine and sears. There are 3 RCTs on fluid rate in severe pancreatitis. All were done by the group of Mao. In 2007, they compared early versus later fluid expansion. In 2009, they compared rapid versus controlled hydration. And in 2010, they compared rapid versus slow hemodilution. Meta-analysis of these 3 RCTs showed that with aggressive hydration, there is significantly higher sepsis, mechanical ventilation, and mortality. This may be due to the previously mentioned pathophysiology, leaving only 20% of crystalloids in circulation after 20 to 40 minutes of equilibrium. As such, aggressive hydration in severe pancreatitis may lead to fluid sequestration and organ failure. The 2015 Italian guideline recommended 20 milliliter per kilogram plus 2 ml per kilo per hour, but the 2012 Spanish guideline recommended not to exceed 3 to 4 liters in 24 hours. Depending on the patient's age, weight, and comorbidities, one may also follow the other guidelines which did not include fluid bolus in their regimen. To avoid fluid volume overload, goal-directed hydration is even more important here than in mild pancreatitis. As to fluid type, isotonic crystalloids are preferred. Lactated ringers is an isotonic pH-balanced crystalloid. Its lactate content is metabolized in the liver by carbonate and thus may reduce pH drop, inflammatory cell activation, and inflammatory response intensity. Low pH activates trypsinogen. Its calcium content binds non-esterified fatty acids and reduces early systemic inflammation. On the other hand, normal saline in large volumes may induce hyperchloremic metabolic acidosis. This triggers secretion of inflammatory cytokines by immune cells and contribute to injury of the kidney, immune dysfunction, and increased pancreatic injury. There are 4 RCTs comparing the 2 crystalloids. All involve mostly mild with some severe cases, except for Lee in 2020, which excluded severe cases, but all included some sears at baseline. A 2021 meta-analysis showed no significant difference in sears, mortality, severe pancreatitis, organ failure, local complications, and need for invasive treatment and enteral nutrition. Interestingly, despite these findings, it showed significantly less ICU admission and a trend toward less pancreatic necrosis, both in favor of lactated ringers. Most of the guidelines recommend lactated ringers. In summary, acute pancreatitis is pancreas attack. Hydration should be immediate to avoid progression of the attack. However, hydration is a double-edged sword, especially in those with severe pancreatitis, advanced age, and comorbidities. To avoid volume overload, such hydration should be goal-directed with frequent checkpoints. Let me end with these beautiful scanning electron micrographs of the pancreas. Thanks for your attention.